I'll be discussing about peripheral vascular disease, how to take a case, how to understand the case, and how to discuss a patient presenting with peripheral vascular disease. So, before we start, there are a few things that we should understand, some kind of basics about blood vessels. So, what we need to understand is there is an arterial tree which starts from the heart through the aorta and its first branches, and then becoming smaller vessels as it reaches the periphery. So, the basic premise is that arterial disease is a local disease but has systemic ramifications. So, you may find that the patient will present with some ulcer or pain in the leg as the basic symptom, but will have problems all over. So, a patient coming with an ulcer in the leg may need to be assessed for a heart disease. Even the coronary artery is a blood vessel, or maybe a stroke because one of the cerebral vessels may be blocked. Now, see, the thing is, peripheral vascular disease, the problem may be, if you can actually see this diagram, let us say, if I can draw a diagram of a vessel, okay. Now, the problem can be inside. It can be in the wall of the vessel, or it can be a swelling outside which is causing occlusion on the inside, okay. But mostly what we think of is the occlusion on the inside, and the commonest cause of occlusion is the atherosclerosis, okay. Now, atherosclerosis actually is like a plaque, a block which slowly starts filling up. So, you find that in in the early cases, you find there is only a small occlusion of the vessel. Now, in this vessel, when a patient exercises, you find that the vessel becomes dilated because of the exercise and normal flow continues. But as the occlusion becomes bigger, let us say about 60% of the vessel is occluded. Okay. Now, the flow is only through this small little area. Even if the vessel dilates, it is not sufficient to meet requirements. The patient will have pain. If it is more than that, let us say about 80-90%, it is a critical occlusion. At this phase, it is not compatible with life. So, that part may die, a process called gangrene. Okay. Now, like we were saying, how do you take a history? So, let us consider the lower limb itself. In the lower limb, you find that peripheral vascular system is the common femoral artery, the femoral artery, popliteal artery, posterior tibial artery, and the dorsalis pedis. These are the blood vessels through which blood comes. So, it can be occluded at any point because of atherosclerosis or any other cause. Commonest is the atherosclerosis. Okay. So, like I said, the patient's first symptoms usually is pain. Okay. And this pain is simply because there is an anaerobic metabolism happening. When the patient does some kind of exercise, it is more like a fatigue, okay, because of the glycolytic cycle. So, you find that, like I showed you just now, anything less than 30%, you find that the vessel can recover, okay, by dilatation. So, when the patient exercises, the patient has no pain, okay. But if it is slightly more than that, we find that the patient may have pain but can continue to walk. Now, this system has been called the Boyd's grading of claudication. So, claudication essentially is a cramp-like pain that is felt distal to the site of the occlusion. So if you have an occlusion, let us say in the common iliac artery, the claudication pain will be felt in the hip or the gluteal area. If the occlusion is at, say, external iliac artery, the claudication pain will be experienced in the thigh. If it is the femoral artery, the claudication will be felt lower down. If it is the popliteal artery, in the ankle and foot segment, etc. So the claudication is at a site distal to the site of occlusion. It is increased or worsened by exercise and relieved at rest. So depending on how much of occlusion is there, we have Boyd's grading 1, 2, 3. So in the grade 1, it is early occlusion. So patient will have pain on walking, but with walking there will be dilatation of the blood vessels and the pain is automatically relieved. Whereas in grade 2 claudication, you find that the patient has pain on walking, but even if the vessel dilates, it is not sufficient to meet the requirements. So, but it is quite okay. So the patient will have pain but can continue to walk with the pain. Okay, and grade 3 claudication is when the patient has pain which forces him to take rest. Okay, so that is the way pain works. Now when you have peripheral vascular disease, it is just not the pain itself, but there are a lot of other problems that can happen, like the parts supplied by the artery, the skin, the integuments, they all can have features of ischemia. Okay, so the patient can come with loss of hair, patient can come with ascites, with dryness of the skin, thinning of the skin. Okay, patient can have an ulceration. Now ulcer is another very important symptom of peripheral vascular disease. And these ulcers are generally present in areas where there is a lot of pressure. The ball of the toe or the heel. These are common areas. Okay. So the patient will give a history of long-standing pain, and then slowly patient can have a history of a ulcer, which now refuses to heal because there is not sufficient blood for the healing process. And along with this, the patient can have symptoms related to other systems, because like I said, arterial system disease is not just to one part. If there's a atherosclerosis in the leg, there can be similar plaques in the other blood vessels. So the patient will have symptoms related to other systems like a heart attack or a stroke or a postprandial pain. If there is mesenteric ischemia, can have features of a renal failure or even blindness. Okay, these are all related to block in the blood vessels. So our problem is with the limb here. So we are going to take history of pain and ulcer. Generally you find that peripheral vascular disease symptoms are more in smokers or anybody who's consuming tobacco. So a history of the etiology for this is also crucial. Why did this happen? When the patient comes with pain, you ask if there is a history of smoking or consuming some medications which can cause arterial constriction, etc. Generally, you find that these symptoms are common in the middle-aged or the elderly and not very common in the younger individuals. However, there is arterial spasm which can occur. Okay, vasospasm, which is seen in a younger individual and more so in women. Okay, so the age and gender also matters in a peripheral vascular disease. Also things like where the patients stay. Somebody coming from a cold climate is likely to have arterial spasm. Okay, people working in industries that have a lot of vibration can also go into these problems. But atherosclerosis is generally in the elderly, diabetic, etc. So that is the age group we are thinking about. They come with pain, where you're going to take a history of claudication, grade the claudication, and the worst case scenario there is that it can progress from claudication, where there is some relief at rest, to rest pain. The patient has pain even at rest. Okay, once the history, you're sure that it is there. You ask where it started, how it has progressed, whether other systems are involved. Okay, and then we progress to things like what are the comorbidities that the patient has. Okay, most important being diabetes or hypertension, which is the etiology for atherosclerosis. So I would say when you're taking a history for a peripheral vascular disease, one thing is how the patient came to the hospital. Is it for pain? Is it for ulcer? Which part of the body is affected? Is there any systemic involvement, other organ systems which may be involved? So you need to take a history for that also. And then comorbidities. One important history that you will take is the tobacco, use of tobacco also. Now, once the history of the patient is taken, we go into a taking history of the family history or past history like a routine case. Okay, then the local examination. Now here, what is important is to see if the patient is obese or thin built, etc. What is the position in which the patient is? Generally, we find that patients who have pain, okay, that is rest pain, these patients sit on the bed with holding the painful part, holding it tight, because that relieves their pain slightly. So it is important to note what is the position of the patient. They also feel better when they hang the foot down. In varicose veins, you find that patient feels better when they lift the leg up. But here, they feel better with the limb down, simply because you find that the blood can flow down with gravity against the smaller blocks that are present. So they may feel a slight relief of symptoms when they hang it down. They you see if they have any other effects of arterial disease, either opposite side or on the other limb or any other part of the body. The pulse is then noted. Now here the problem is that some pulses will be felt, some may not be felt. Okay, but taking a pulse is another very important part of the peripheral vascular system examination. So we will describe that, let us say, in the palpation part of it. But at this point, what we want to know is whether pulses are palpable all over. So you say where it is palpable and the other not palpable, and you will be describing it sometime later. Okay, check the blood pressure. Now blood pressure is again one important thing here, because measuring the blood pressure in the upper limb and then in the lower limb and comparing the two gives us a specific thing called the arterial brachial pressure index. Okay, now generally what is required is to have a arterial Doppler for this measurement, where you feel the brachial pulse, you feel the pulse in the dorsalis pedis or the posterior tibial. So here in the upper limb you put BP cuff in the arm, in the lower limb you put it somewhere in the calf. and measure the systolic pressure and compare it. Generally, you find that it is about the lower limb pressure is slightly higher by about 20 millimeter mercury, okay, or it may be normal. But as there is an occlusion, you find that the pressure index comes down. What should have been 1 comes down to 0.8, 0.6, 0.3, etc. And that correlates with the amount of circumference that is lost in the artery, the one I showed you at the beginning. So you find that as there is more and more occlusion, the AV index becomes lower and lower. If it is less than 0.3, less than 0.3, you are going to think in terms of a condition called critical limb ischemia. Okay, but by definition, critical limb ischemia is when a patient has pain continuously for more than 3 weeks, okay, with an artery and with an ABI of less than 0.3 and a toe systolic pressure of less than 50 millimeter mercury. Or if the patient has a non-healing ulcer for more than 3 weeks, and the same thing, ABI less than 0.3, etc. Now these are the criteria for a critical limb ischemia. This is the point where you just happen to need to intervene. But if it is more than that, let's say it is at 30% of the circumference which is occluded, or 60%, and the patient still can do well. Now this is a area where a lot of conservative management can be tried. So our aim at examination is to find out how much we can conserve, how much, where we need to actually intervene, etc. Now, the local examination is of the lower limb, where the first thing that you're going to see is compare the two limbs. If it is lower limb, two limbs you're going to compare. This should be in a very well lit room with the patient in sitting, in standing position, etc. Now you are going to compare to see if there is any wasting of one of the limbs, especially so in the limb where there is loss of blood flow. Okay. The next thing that you can see is what has the arterial occlusion done to the skin and all its integuments, like the nail or hair or fat, etc. So you find that there is actually thinning of the skin, discoloration in the skin, okay, and there will be loss of hair, loss of subcutaneous fat when there is severe arterial occlusion. So you are going to look for that and compare with the opposite side. So like you all know, it is inspection, percussion, inspection, palpation, percussion, auscultation. So what we're going to do first is the inspection part of it, where you are inspecting for the two lower limbs. You're looking at if there's any color changes. You're looking at the skin and all the other things that are there in the skin. Okay, whether the nail is present, not present, if it is brittle or normal, etc. These are all appendages. Then, in some patients, you find that they may already have had this disease earlier, and they have probably done something to it. Meaning an amputation may have been done, or there may be a healed ulcer there. These are all to be noted, scars and things like that. Then you start looking at the features, meaning you're looking at whether arterial system or venous system or neural system are being affected. Now in this context, in the history, one important thing is that when you're taking the history of pain, you find that you have to differentiate between the arterial, venous and neurological claudication. Arterial claudication, what is important is that there is no pain at the first step. Okay, there is a requirement for exercise. So only when the patient starts walking will the pain come. Okay, and it is relieved at rest. Whereas in a venous claudication, the pain comes on change of posture. On elevation it is improved, but when the patient keeps the limb in sitting or standing posture, pain can get worsened. A neurogenic claudication, the thing is that pain is present even at rest. It is there at first step. So that's how you differentiate. The same thing applies when we are doing the inspection. You're supposed to look at the three systems: artery, vein and nerve. When you look at the artery, what can you see there? Can you see an artery? You cannot. But you can see the effects that the arterial system has on the skin. You can see the color. Okay. So you see if the limb has become, say, white or black, or there is loss of red, etc. The capillary filling in the limbs is making it, especially the sole and all that, you can find that it is red. Nail beds are red, etc. Now what you do, a small test which is the Berger's test, wherein you ask the patient to lift the leg up. Okay. Now as the patient lifts the leg up, it is going against gravity, and I told you that the patient feels better keeping the foot down because of gravity. Now against gravity, when they go up, at a certain angle you find that the limb which was previously red starts becoming white at some point. If you note the angle with the horizontal, that makes it the Berger's angle. Okay. And as you go up, the limb starts to become white. Whereas when you drop it down, you find that the blood starts coming into the system and the limb which was previously pale becomes congested. So pallor on elevation and congestion on dependency is the system of Berger's test. This is an inspectory finding. When you're doing this inspection, you also look at the veins. If there were a normal blood flow, arterial flow inwards, there will be a normal flow outwards also. You find that the veins become turgid and they are normal. Whereas if the flow inside is less, you find that what is going out is also less. Consequently, you find that the veins are kind of guttered. Okay. The nervous system, nerves, you're going to see for any wasting of muscles or any loss of movements in the toes and joints, etc. Okay. This is apart from all the scars and sinuses and things like that you're looking for. So essentially you're looking for the effects that the blood flows of blood flow on the skin and its appendages. For the arterial system, Berger's test, vein and nerve, and the joints. Okay, all the way. And you can compare with the opposite side, because like I said, it can be multi-centric disease. It can be in different parts of the body. Okay, so but you compare for a normal side, the opposite side at least. Now go to palpation. Now when you palpate, what you do is, first thing is to touch and feel. So you feel that where there is no blood flow, obviously the limb becomes cold. And this coldness can be done in two ways. From above, from below upwards, you see till where the limb is cold, indicating the level of occlusion. You can compare with the opposite side, opposite limb also, whether the similar part of the body is cold or hot. Okay. Now this test needs to be done in a normal room without the patient under a blanket, because many times what happens is, if the patient has been under a blanket for a long time, the ambient temperature of that area is also reflected on the leg. So an otherwise cold limb may feel to be warm sometimes. So it is important that you wait for some time before you touch and feel. Okay, what's the natural temperature of the limb? And then you look for tenderness. Now in the peripheral vascular system, you find that in the problem is that even the nerves are supplied by blood vessels, and where there is arterial occlusion, the nerves tend to die and they start reacting. Okay, so you have this thing called rest pain because the nerves are dying. It is called the cry of the dying nerves. You find that in many patients, it is not simply just some discoloration or ulceration, but on inspection you do find sometimes that there is gangrene appearing. Now what is gangrene? It is death with superadded putrefaction. So we were talking about the ischemic changes. You can also have actual frank gangrene. Okay, gangrene, I will tell it to you in the next thing. Now, on palpating this area, you find that the dead parts are cold, whereas the live parts may be warm. And there is a margin in between the dead and the living. Okay, this particular zone has nerves which may be hyperesthetic, increased sensation. So there, when you touch and see, you may have an increased sensation of pain. The dead areas, you find that there is no movement. The muscles are wasted, the muscles are dead, they don't have any function. So the joints do not move. And on palpation, now earlier we were trying to look at the capillaries. Now you can actually press on the area. Okay, press on the nail bed and leave it and see how fast these capillaries fill up. Generally it should fill up immediately. But if there is a delay, it indicates that the blood flow is less. And similarly, if for the Berger's test, you can actually raise the limb physically and see till where the thing is becoming white, congestion, etc. Okay. Now, you can also palpate for individual pulsations. Now, the pulsation of the dorsalis pedis is palpated just lateral to the extensor hallucis longus muscle there. Okay, that is somewhere over the say head of the first metatarsal. Somewhere there you palpate. That is the dorsalis pedis, which is normally absent in about 10% of the patients. But you start from there. You palpate the posterior tibial artery, just behind the medial malleolus. You palpate for the popliteal artery. The popliteal artery can be felt in two ways. Either by folding the leg and holding it from behind over the femoral bone. So remember, all the arterial pulsations are to be palpated over a bone. Okay. So you can either from the back, you can hold it like that from the back and then feel the artery over the femoral bone, or in the prone position, you can feel it over the head of the tibia itself. Okay?
My city.
You can feel it over the tibia itself. Now, the other artery that you're feeling is the femoral artery at the femoral triangle. This is felt over the head of the femur. Okay? Below the inguinal ligament is the femoral artery, and just above that you find the external iliac artery pulsation. So you can actually palpate both of them. And in extremely thin individuals, you can also actually palpate the aorta also in the epigastric region. Now, these are all pulsations that you should feel. Now, when you're feeling for pulsations, what you're going to feel is the rate, rhythm, okay, the volume of the pulse. You're also feeling the vessel wall. Now, in a normal person, you find that it is very nice and elastic. You can actually palpate. But in these patients who are atherosclerotic, you find that when you try to palpate the artery, that is hard, almost cord-like. Okay? Now, that is something that you need to feel. So, that is the lower limb arterial supply. Right? You look at the venous drainage. Now, venous drainage, I said it is on inspection, it was just guttering. But on palpation, you do what is called as the Harvey's test, where you can actually kind of see these vessels. These are vessels here, it's a vein. You keep two fingers and push it up in the direction of the heart. Okay, keeping the proximal finger compressed. You find that the vein is completely occluded. There is no flow in the vein. But the moment you release it, the vein fills up immediately. But in an arterial occlusion where there is no flow, this vein remains guttered and there is slow filling of the vein. Okay? You also palpate the rest of the leg for sensations, till where is it present or absent, etc. Look at the joint mobility, etc. Okay? Now, this will be the main aspects of the inspection and palpation. Now, what I have to talk about is the gangrene. There are two types of gangrene. One is called the dry gangrene, the other is the wet gangrene. It is the dead, decayed tissue. Okay, when there is a slow arterial occlusion, like atherosclerosis over a long period of time, the limb slowly shrinks and dies off. So you find that the shape of the limb is maintained, but it is becoming like a mummified limb, small, very dried up stuff. Okay, and there is an actual margin between the normal tissue and the dead tissue. Whereas if it gets infected, if that gangrenous tissue gets infected, you find that this margin is not very clear. Okay, it is a wet gangrene. Now this wet gangrene can also occur in diabetes, where it is completely infected. Okay, or when there is a sudden occlusion. Now, occlusion need not always be chronic. It can be because of an embolus. Now in such cases also it is dead. There is death and putrefaction, but you are not able to make out a margin because there is no time for the tissues to actually show up as dead or alive. Right? So it becomes a wet gangrene. Many of the patients with a peripheral arterial disease have a failure of healing process. You understand that for wound healing there is requirement for blood. Only then epithelial cells will come up. If it is not coming up sufficiently, it remains as a breach in the continuity of the epithelium, an ulcer. And this ulcer typically has a punched out edge in peripheral arterial disease. Okay. In a peripheral arterial disease, you also talk about percussion, auscultation, but here the auscultation is what is more important. At the area of the occlusion, sometimes when you keep it carefully, you can hear a bruit because blood is passing through some kind of resistance. At that area, you can hear a sound, but otherwise, auscultation has nothing more here in this area. Now, the examination of the peripheral vascular system, especially in the lower limb, is now still incomplete. You have to find out about the abdomen because all these are continuous vessels. Occlusion may be in one area, but it may be present in other areas also. And like I said, the occlusion need not always be from the inside. It can also be from the outside. Something from outside pressing on the artery. Say a big soft tissue tumor in the abdomen can press on the aorta and cause occlusion. Okay. So you have to find out if something like that is happening. So what do? You examine the abdomen just like other systems, inspection, palpation, percussion, auscultation. But in this case, you are looking for any features to suggest some mass in that area. You are looking at the aorta to see if it is palpable or not. In a normal individual, it is not palpable. But if it is palpable, it indicates that the size has become increased. A condition called aneurysm. Okay? Aneurysm is a dilatation. Even in that, there can be occlusion because this aneurysmal area can have blood which is stased and thrombosed. Okay. Now, this thrombosed blood can cause occlusion. It can escape to the peripheral areas and cause an embolus, a wet gangrene sometimes. All this can happen. So, you are palpating to see all these things. Okay. You examine the upper limb vessels for any signs of occlusion, the radial, brachial, axillary, the brachiocephalic, subclavian, okay, and even the carotid vessels. Now all these vessels may have issues. So when a patient comes with a small ulcer or pain in the leg, you have to examine all these systems because of that. And also examine the eye, the vision. Okay, look at the central nervous system for any evidence of ischemia. The patient can have features of neurogenic pain and loss of sensation, giddiness, trauma, whatever. And last but not the least is the cardiovascular system, okay, which also is a arterial system, the coronary vessels can also be included, can be involved. You find that most patients with peripheral vascular disease problems, like a pain in the leg or ulcer in the leg, even if they are treated in the next 2 years, they are likely to die of a stroke or a heart disease if they are not treated adequately. So that is why when they come with this, you are also examining all the other systems. Only then the examination becomes complete. Okay. Now, once you reach this stage, your diagnosis is going to be either claudication or ulcer, definitely, due to peripheral vascular disease. Now, our issue is to find out whether it is because of an acute occlusion or a chronic occlusion. And in a chronic occlusion, what is the reason for it? Is it only one system or multiple systems? Okay. Now, how do you evaluate the patient? The most important evaluation is the basic tests that you've done, the ankle brachial index, the peripheral vascular system palpation, and all those things. Now, apart from that, you can also do a arterial Doppler. Now, in this case, it is called a duplex Doppler. Okay, it is a non-invasive scan to assess whether the pulsation is present, if there is an occlusion in the vessel, how long is the occlusion, is there a reformation elsewhere, etc. All this can be made out on a arterial Doppler. You can also do a simple scan of the abdomen to see if there is any other pathology in the abdomen. An echo or a X-ray, ECG of the ECG, all these are important tests in this patient. Now, the blood tests that you do are basically to assess whether the patient is a diabetic, whether he has any renal failure, okay, whether he has any other arterial, meaning, what do you call this? Complete blood counts to see his hemoglobin and things like that. Now, all these, once that is done, you are going to assess the patient again for treatment. Now, like I said, if it is a arterial system disease where the ABI is more than 0.6, 0.3, it can be treated possibly conservatively. Okay, and the most important part of the treatment then is going to be to avert or stop all the etiological factors, most important being smoking. So, stop smoking and start exercise, which can actually improve, or it can dilate the vessels and improve the blood flow. The other, if the patient has a critical limb ischemia, it means that if something is not done, the patient will tend to lose the limb. So, in such patients, we need to do an intervention. So, when we plan for an intervention is the time when we do interventional procedures like an angioplasty. Okay. Otherwise, we are going to limit ourselves to an arterial Doppler. But here, we are going to do an angioplasty, which will again give you all the picture. You can actually see it. They inject a dye by a Seldinger technique, and they can actually see the length of the vessel, the diameter of the vessel, whether there is any occlusion, whether it is single occlusion, multiple occlusions, where is it reforming, etc. And that will give the surgeon an idea as to how to go about revascularizing again, okay, either by an angioplasty or by a bypass, etc. Now, once you've embarked on it, once you embark on angioplasty, then you may have to do an interventional procedure, a treatment part of it. There is one other semi-interventional thing that you can do, which is the CT angiogram or a MR angiogram. Okay, this again gives you a good picture of what the level of occlusion is. The only thing is, because you are injecting a dye, you should be fairly certain that their renal parameters are normal. So you get a creatinine tested. So the patients with peripheral vascular disease, you're going to evaluate. History taking is going to be for what is the effect on the body, whether it is pain, ulcer, or gangrene, okay, or whether there is any other previous history like that. You're going to look at the etiology, whether it is a acute or a chronic pain because of atherosclerosis or diabetes, etc. Then you're going to see if other systems are involved: heart, lung, kidney, brain, eye, mesenteric artery, etc., or even the upper limb. And then you do a palpation, inspection and palpation to see the limbs. Okay, palpate all the peripheral vessels till where is the occlusion. You should understand about the Boyd's grading, about claudication, wherein I said that it is a cramp-like pain distal to the site of occlusion. Okay, that will show you exactly where the start is of the occlusion. Now, once you have done a clinical examination, you decide on whether you're going to manage conservatively or by intervention. So, conservative management is what is mostly done, and there it is you're going to do a arterial Doppler only. That would or a CT angiogram sometimes. But if you are planning to intervene, like in a chronic limb ischemia, there you may have to do an angioplasty and treat with medications and all these things. Okay, so this is going to be roughly the format for the examination of a peripheral vascular system. So I hope all of you can understand and do well. This is at least the basic of how the examination goes on. Other systems, each of the other systems, the abdomen and cardiovascular system, upper limb, are all different parts of the peripheral vascular system to be examined. Okay, that becomes too much for one single video. But at least if you can understand the basics here, I would be happy. So all the best for your exams. Thank you.